folks, welcome to our lecture on the respiratory system. This is going to cover all of our anatomy and physiology. We're going to talk about common diseases of the respiratory system, including some that you have probably heard ad nauseum in the news in the last couple of months. These are our objectives for the lecture. If you are comfortable with these, you should do very nicely on the quiz over this on Wednesday. If you have any questions about these objectives, or if you're not sure how to get comfortable with them, definitely send me an email or drop by during office hours. I would love to talk with you. So before we get started talking about actual respiration, I want to go over a couple of vocab words just to make sure that we're all on the same page. When we talk about the respiratory system and we talk about respiration and ventilation and breathing, usually we're talking about these things interchangeably. Breathing is the same as respiration, is the same as ventilation. When we get very technical in respiratory physiology, no, they're not the same thing actually. So breathing, the act of breathing, what you all are doing right now, I hope, is ventilation, moving air in and out of lungs. When you guys get to your CPR, and you learn how to do artificial ventilation with a bag mask on your dummies, that's ventilation as well. What we call respiration, when we get very technical, is actually this, gas exchange. Dropping off oxygen and picking up carbon dioxide, or vice versa, depending on where we are in the body. Let's look very quickly at some overall anatomy in the respiratory system. We can divide the respiratory system into a top or an upper and a lower respiratory system. And the divide is generally speaking about here, right on top of the larynx. If you've ever gone to the doctor and they tell you, oh, you have an upper respiratory infection, that's what they're referring to. So the upper half of the respiratory system consists of basically your nose and your throat. And I want you to take a minute, touch your throat. Probably you have your hand on your neck. That's quite often what we think of when we think of the throat. In reality, when we get very technical anatomically, your throat is this area right back here, behind your mouth, behind your nasal cavity. We call it your pharynx. It sits above your larynx, which is your voice box. And it's not really in your neck at all. It's just the back of your head, behind your nose and your mouth. Going down from there, we find the larynx. This is what you would commonly call your voice box. The trachea, or your windpipe, which comes down and branches left and right into primary and secondary bronchi. And then those bronchi branch and branch and branch and branch like a branch on a tree. They branch off until we get to these tiny little alveoli, little air sacs. This is where all the magic happens. This is where all the oxygen in your air gets put into your blood, where all the carbon dioxide in your blood gets put into your lungs to be exhaled. So the main function of the respiratory system is to get oxygen to your cells and get carbon dioxide out of your body. And it does this working very, very tightly with the cardiovascular system, get this gas exchange. Remember, gas exchange, this is our word for respiration. Right? So we have external and internal gas exchange. External gas exchange happens between the atmosphere and the blood. And I know it says that it's external, but this happens in the lung. We call it external gas exchange because your lung's exposed to the external environment every time you breathe. Internal gas exchange then occurs at the cells, at your cellular level. You're going to drop off the oxygen that's in the blood and pick up carbon dioxide to bring it back to be breathed out. We carry oxygen in the blood attached to hemoglobin. Hopefully that's a word that you've heard before. That's a protein that we talked about in the cardiovascular system lecture. Hemoglobin is in your erythrocytes, your little red blood cells, and it carries oxygen. Hemoglobin is a very special little protein. it changes its shape based on whether or not it's in an environment with very high or very low oxygen. If it's in an environment with really high oxygen, it will change its shape to hold very tightly onto oxygen. When it gets into an environment with very low oxygen, it changes its shape again and releases that oxygen into that low oxygen environment. Carbon dioxide does not travel in hemoglobin. It gets dissolved in your blood as carbonic acid. And I want you to remember that because we will come back and visit this concept later in lecture. But this acid is what helps monitor your pH in your blood, which is something else that hopefully you talked about in your last lectures when you talked about the heart and the blood. pH, remember, is how we measure how acidic or basic something is. If it's a substance that has a pH less than 7, it's acidic. If it's a pH of greater than 7, then it's basic. Your blood pH, we want that to be pretty neutral, 7, I think like 7.4 technically. And we keep that level, that pH, using the acid in the blood, which is carbonic acid. So looking at your upper respiratory system, air goes into your nose, into your sinus cavities. It goes down to your pharynx, which remember is essentially your throat. And we can divide the pharynx into these 3 regions depending on where you are in the pharynx. The nasopharynx sits right behind the nose, the oropharynx sits behind the mouth, the laryngopharynx sits at the bottom of the pharynx right on top of the larynx. The epiglottis kind of marks our distinction between pharynx and larynx, between upper and lower. This is a little piece of cartilage that covers the trachea. So you can see down here, there's your trachea going down. And this little flap of cartilage on top of it is what keeps food from going down into that trachea. Food or drink or medicine or anything that's not supposed to be in your lungs except air. Every time you swallow, food hits that epiglottis and kind of slaps it shut on top of the trachea, and food goes down into your esophagus. Now, this is not always perfect, and you know that if you've been, out eating and all of a sudden you're coughing and coughing and coughing to cough up a lung because you got that water or that food down underneath your epiglottis. But overall, it's pretty good. If you do get something underneath your epiglottis, if you do inhale food or drink or anything that's not supposed to be in your lungs into your lungs, we call that aspiration. You've aspirated something. And that's bad because there may be bacteria on there, there may be viruses on there, and that increases your risk of infection in the lungs. This is a big concern with patients who can't swallow well. So think like a recovering stroke victim who's relearning how to swallow. Below the epiglottis, we find the larynx, and the larynx you sometimes hear people call your voice box. It has your little vocal folds. These are little bands of membrane that vibrate back and forth when air is passed over them, and they're what help you speak. Below the larynx, we find the trachea, which is also commonly called your windpipe or your wind tube. It's a little tube with rings of cartilage separated by bands of membrane. And you can feel that. If you tilt your neck back a little bit, feel the front of your neck, push a little if you have to with your fingers, you should be able to feel little ridges on the front of your neck. That's your trachea going down into your chest. The trachea divides at the bottom into 2 left and right primary bronchi, and then those bronchi divide even further. Think of a tree branching out. You have the trunk of the tree would be the trachea, and then you have your first 2 branches, which are your primary bronchi, and then they branch again, so now you have secondary bronchi and then tertiary bronchi, and eventually you branch and branch and branch until you get to these tiny little bronchioles. This suffix here, ol, this is the diminutive form. This just means small. I think the equivalent for this is like ito or ita in Spanish. In French, it's et to denote something that's small. So bronchiole is just a very, very small bronchus. And then at the end of your bronchioles are your alveoli. Now the trachea and your bigger bronchi are lined with cilia. that helps keep the trachea clean. That's what these little guys are here, down at the bottom of this. Cilia are little hair-like cells, and they move. They constantly sweep upwards, moving up your trachea up towards your throat, up towards your mouth. And as they wave and sweep upwards, they carry this layer of mucus on top of them. And this mucus traps bacteria, viruses, parasites, anything that shouldn't be in your lungs. It's going to get stuck in that mucus and carried up to the back of your throat. And that's why every so often you find that you need to clear your throat, cough or swallow, because you've got that mucus being carried up by that mucociliary escalator. Now, this is a great way to keep the lungs safe and trap any particles, any pathogens that might have made it past the nasal cavities. But the mucociliary escalator can also be damaged. Smoking will play a huge number on it. Exposure to air pollution, certain toxins will as well. And if that happens, that makes it really hard to get that mucus out of the trachea. And that means that all those bacteria that are stuck in that mucus is going to stay in there as well. So you see increased risk of infection with damage to that mucociliary escalator. This is just looking at the larynx and the top of the trachea. This is our larynx right here, also called your voice box. Here's the epiglottis up here that's making sure that food does not go down into the larynx. And then we see the trachea down at the bottom here. These little rings of cartilage and then little bands of membrane in between to give it some flexibility. At the bottom of the trachea, where it divides, it bifurcates into left and right primary bronchi. This little spot right here is called the carina. The carina is very, very sensitive. If you were to get food or drink down the trachea and it hit the carina, you would cough and cough really hard and cough that food back up. So we go from the trachea to our left and right primary bronchi. And then those primary bronchi split into secondary bronchi, the secondary bronchi split into tertiary bronchi, the tertiary bronchi split into quaternary bronchi, and they keep branching off and off and off until we get tiny, tiny little bronchioles that you can't see with the naked eye. Over here, this spot in the lung where the bronchi enter the lung, this is called the hilum of the lung. So looking at the anatomy of the lungs, then the right lobe is larger than the left lung, the right lung is larger than the left lung. The right lung has 3 lobes, the left lung has 2 lobes. What happened to our left lung? Why are we missing a lobe? Don't we kind of want that? Where did that 3rd lobe in our left lung go? We lost our 3rd lobe because instead we have a heart sitting right there. This little area in the left lung is called the cardiac notch. And if we were to take it and turn it 90 degrees so you could see inside, you'd see there's a perfect little groove there for a heart. That's not anatomically correct, but you get the idea. The lungs are covered by pleura. This is a smooth, slippery, thin little membrane that wraps around the lungs and the inside of the thoracic cavity. It helps to hold the lungs in place. It helps to keep them from rubbing up against the chest wall. Occasionally, in a patient with a really bad infection, maybe a really bad case of pneumonia, you'll sometimes see buildup of fluid in between these layers of the pleura. And when that happens, that compresses the lung, and then you need to get that fluid removed so that your patient can breathe. We'll look at that in a little bit later. All right, so here's our bronchial tree right here. We've gone from the trachea into the lung on the primary bronchus, and it's branched off into secondary and then tertiary and then quaternary bronchi and then tiny, tiny little bronchioles. And down at the end of our bronchioles, we branch 23 times. After our 23rd branch, which would be this right here, we find our alveoli. This is where all the magic happens. This is where all of the air that you breathe in is going to go, and all of the oxygen in that air is going to transfer into the little capillary beds that are wrapped around the alveoli. Carbon dioxide in your capillary beds will travel into the alveolus so that then you can breathe out that carbon dioxide. The alveoli are very small. They're tiny. You can't see them with the naked eye, and also they're very thin. The wall of an alveolus is only 1 cell thick, which means that a whole lot more than oxygen can cross the alveolus and get into your bloodstream. We'll take a look at some of the implications that that has in a little bit. This is just an overview of your heart and your lungs all working together to move oxygen all throughout your body. I would, spend some time looking over this, make sure that you're comfortable with all the concepts that we see here. If you're not, drop by office hours or give me an email. We can talk about it. I'm not going to read over all of our roots and combining forms that we have here, just because you don't want to hear me read all of those out. So I will point out a couple of roots that you should definitely know for your quiz on Wednesday, and those are freno, and frenico. Anything with freno or frenico refers to your diaphragm, or the nerve that innervates your diaphragm. We always remembered that in grad school when we were doing dissection, we would talk about how the phrenic nerve is the friend of the diaphragm, and that was how we remembered the connection between the two. Whatever works for you, just make sure you know that for the quiz. Another thing that I would definitely know for the quiz is this suffix capnia. Capnia refers to carbon dioxide, specifically the level of carbon dioxide in your tissues. All right, so 2 steps to breathing, inhaling and exhaling, inspiration and expiration. Breathing in is all run by your diaphragm. He does all of this. The phrenic nerve innervates your diaphragm, it activates the diaphragm, and the diaphragm flattens. Normally the diaphragm is kind of curved, almost a dome shape underneath your ribs. When the phrenic nerve activates it, the diaphragm flattens out. That enlarges the volume of the chest cavity, and that causes air to get sucked into your lungs. Your lungs don't do anything. Your lungs don't have any muscle. Your lungs are completely passive. When you breathe out, you relax that diaphragm. It goes back to its curved dome shape underneath your rib cage. That makes the volume of the chest cavity get smaller, and that forces air out of the lungs. There is no muscle that helps you breathe out. You're just relaxing the diaphragm. Breathing is controlled by your autonomic nervous system. That's the nervous system that does all of the really important stuff that you don't want to have to think about, because if you did, you'd die when you went to sleep. It does your breathing, it does your heart rate, it does your blood pressure, all sorts of things like that. And how quickly you breathe has to do with the amount of carbon dioxide in your blood, which probably seems very counterintuitive. You say, but wait, Miss Catherine, wouldn't we want oxygen to tell us when we need to breathe? Wouldn't we want to breathe more when we have low amounts of oxygen? And the reason why carbon dioxide is the one that tells us when to breathe is because carbon dioxide, remember, in your blood is dissolved as carbonic acid. Remember, we don't carry it on hemoglobin, we dissolve it as an acid. Think about just acid in general. What comes to mind when we talk about acid? Hopefully not tripping on acid. If that's the first thing that comes to mind, please come talk to me. But maybe something like acid can be very destructive. Think about like the acid in your car battery, for example, or the acid in your stomach. Acid is destructive. Acid kills stuff. And the same is true about carbonic acid in your blood. If you have high levels of carbonic acid in your blood, that's going to wind up killing off or at least destroying your cells. We don't want that. If your cells die off, if your cells get destroyed, then you die off, and that's not good. So that's why carbon dioxide is the gas that mediates how much we breathe, because we're trying to control that level of carbonic acid to keep it just perfect so that we don't have too much and get very acidic and kill off our cells, or so we don't have too little and get very basic and kill off our cells as well. Normal respiratory rate for a human is over here. If you've ever been around a little newborn baby, you know they breathe really fast. They're like little hummingbirds. one breath every second to second and a half. The older you get, the more that slows down, until as an adult, you should be taking one breath every 3 to 5 seconds, 12 to 20 breaths a minute. Anything higher or lower than that is cause for concern. This is just looking at the act of breathing, how it changes the shape of the diaphragm. You can see here the diaphragm's kind of flattened when you breathe in. When you breathe out, the diaphragm relaxes and goes up to a very domed shape here. And that's what causes the changes in pressure in the chest cavity that ultimately causes the air to go in and out of the lungs. Some key terms here, these will be very helpful as you're studying for your quiz and as you're working on your homework. Again, I'm not going to read all of these out because you don't want to sit there and listen to me read all of these out. But do spend some time looking over these. If you have any key terms that you're not sure about or you have questions about them, shoot me an email or drop by office hours. Okay, let's start talking about some pathology. Before we go too deep into pathology, I have one quick topic that I want to go over with all y'all. If you pay attention to the news, which generally speaking my students don't, at least not until this year, you may have noticed back in like 2017, 2018, New Delhi surpassed Beijing as the most polluted city in the world, the worst air pollution in the world. Look at that picture. That would be really cute, like mom and her little kid, if this was like mom and her little kid on a cute foggy day. In reality, that's not mom and her little kid on a cute foggy day. That's mom and her little kid with breathtakingly high amounts, literally, of air pollution. From cars, from trucks, from factories, from burning biomass to cook or heat your home, from lots of stuff. So let's talk very briefly about air pollution. Air pollution includes a whole bunch of stuff. It includes tobacco smoke, ozone, gases like sulfur dioxide or carbon monoxide, fine particulate matter. This is little microscopic particles that you can't see that are released when you burn stuff. You can't see them, but they go into your lungs when you breathe them in. They cross your alveoli and get into your blood. We know that they can be found in the blood. We also know fine particulate matter will cross the placenta. Think about the implications behind that. We know that air pollution is a carcinogen. The World Health Organization declared it a Class 1 carcinogen back in 2013. And it is linked to an increase in all kinds of issues. Respiratory diseases, especially our 3 chronic respiratory diseases, which are asthma, bronchitis, and emphysema. Also increase in cardiovascular disease. Also adverse pregnancy outcomes. Going back to air pollution crosses the placenta. By adverse pregnancy outcomes, we mean things like small for gestational age, low birth weight, premature birth, stillbirth, miscarriage, that sort of thing. We also know that babies who are born to mothers who were exposed to a lot of air pollution are much more likely to develop asthma as they grow, much more likely to have asthma during childhood. Estimated that air pollution causes excess of 7 million unnecessary deaths per year, and also that most of the world's population is living somewhere where the air pollution standards are not met, where the air is not good. And then this last statistic here, which I think is kind of sobering and maybe a little damning, air pollution accounts for almost 10% of deaths in children under 5, usually because of either asthma or pneumonia. Upper respiratory infections like asthma, or upper respiratory infections, asthma, and pneumonia tend to be the biggest respiratory killers of very young children. So think about practically what would this mean? How would you apply this to your patient? You are an MA working up at UC Health, and mom just came in with her little 6-year-old. Her little 6-year-old just got diagnosed with asthma. Mom's all frantic. I don't know what I do. How do I take care of him? What should I know about asthma? Knowing what you know now about air pollution, what kind of conversation would you have with her? Do we measure air quality? Can you find that anywhere? What would you tell her on days when the air quality is really bad? What about keeping the air clean in her house? What should she know? And think about how that would affect your patient. And also, as we go through a lot of this, you're going to see air pollution come up time and time again as a cause of many of the things that we're going to talk about in this lecture. All right, as you get older, you see changes everywhere in the body, and the respiratory system is no exception. Your tissues just in general aren't quite as elastic anymore, so the chest wall doesn't expand as well, and it's harder to breathe in and harder to breathe out all the way. You are much more susceptible to getting an infection. You see an increase in lung disorders. Quite often, your patient, your older or debilitated patient, is fighting off pneumonia. Pneumonia tends to be a big killer in debilitated patients. Some stuff that will affect the function of the lungs, resistance to airflow is a big one. Think, for example, if you have a patient with a bronchus that's nice and big and open versus maybe your asthmatic patient whose bronchus is really, really small because it's inflamed. Conditions that will keep you from expanding the chest all the way. Maybe your patient has a broken rib or two and they don't want to breathe in really deeply because that hurts. And then we're going to look at conditions that will directly affect the respiratory system. Lots of infectious diseases, some cancers, things along those lines. If you see breathing changes in your patient, either they're breathing too fast or they're breathing too slow, that can lead to changes in blood pH. And that's not good because if we throw off the pH of the blood, we throw off a lot of other things in the body as well. Alkalosis occurs when your patient is breathing too fast, and that will turn the blood basic or alkaline. That means that they're breathing off too much carbon dioxide. Acidosis is just the opposite. This is when we have hypoventilation. Your patient is breathing too slow, so you get buildup of carbon dioxide in the blood, and the blood actually becomes acidic. We see this sometimes with opiate overdose because opiates, heroin, they suppress the respiratory system. They make you breathe slower as a side effect. But if you take a whole bunch of opiates, that will significantly slow down your respiratory system to the point where your blood will get acidotic. And sometimes that can be a concern if you're dealing with someone who's overdosed or been overdosed for a while. Let's talk about some infections. Pneumonia is caused by a few different microorganisms. It can be caused by bacteria. It can be caused by a virus. It can be secondary to another infection, and that's what we're seeing with a lot of our COVID-19 patients. They are developing pneumonia because of the inflammation that's going on in the lungs caused by that virus in there. There are different types of pneumonia. You can have pneumonia of the bronchus in the lung or the bronchial tree. You can have pneumonia of a whole lobe of the lung. You may have heard of walking pneumonia, which is not pneumonia walking around your lungs. It's just your patient is well enough to be up and walking. They're not debilitated because of the pneumonia. So if you don't take care of that walking pneumonia, it can turn into lying in your bed praying for death pneumonia. Like I said earlier, pneumonia is the leading cause of death in your debilitated patients, usually because they're already in kind of bad health, and also because a debilitated patient usually can't cough and clear their lungs very well, so you have a lot of infectious material just still hanging out in the lungs. Tuberculosis is caused by Mycobacterium tuberculosis. It's a bacterial infection. Signs that you have tuberculosis, usually a fever at night and really bad night sweats. You wake up in the middle of the night with a really bad fever, drenched in sweat. On top of that, unexplained weight loss. I'm not exercising more, I'm not dieting more. Actually, I'm stuck at home, like eating bags and bags of Doritos and hot Cheetos, and still I lost like 30 pounds in the last month. If you were to call up your doctor and say that you keep waking up in the middle of the night with a fever and you've lost like 30 pounds, they will tell you to come in and then they'll stick you in a negative pressure room so you don't infect anybody else because you'll make them very nervous. You'll see weakness and fatigue as well, cough, and then the other kind of really concerning sign with tuberculosis, hemoptysis, so coughing up blood from deep in the lungs. We'll talk a little more about TB in a minute. Influenza is a viral infection. We've all had the flu before. You know the signs and symptoms of the flu: chill, fever, muscle ache, headache. You kind of feel like death for a week or so. We tend to have regular pandemics of the flu go through. The biggest one in recent memory was back in 1918. Everyone's talking about that now and comparing this current coronavirus outbreak to our 1918 flu pandemic. A couple years ago, 2017 to 2018, we also had a pretty nasty flu season as well. The common cold is caused by a number of different types of viruses: rhinovirus, adenovirus, coronavirus. Based on the name here, rhinovirus, you would assume lives in your nose. Coronaviruses, I know we're talking about the coronavirus right now. It's not the only coronavirus out there. There are lots of different types of coronaviruses. Most of them cause just the cold-like symptoms. Some of them can get kind of nasty. SARS and MERS are examples of those: severe acute respiratory syndrome and Middle Eastern respiratory syndrome, which are previous outbreaks that we had with some nasty coronaviruses that were even worse than the one that we're dealing with now. So let's talk about COVID-19, because I'm sure you're dying to talk about that. First infection of COVID-19 was reported in December 1st in Wuhan, China. Since then, there have been a lot of questions about the ethics and straightforwardness of the Chinese government, as there always have been and always will be. But that was when the first infection was reported. Quite probably, it was circulating in the population long before that. It was linked to a wet market. This is a very common way that we see viruses and bacteria jump from animal to human populations. A wet market, if you're not familiar with the term, is a place where you go to pick the chicken that you want for dinner. You look through all the cages, you say, I want that chicken. And then the person selling you the chicken takes the chicken in back, kills the chicken, butchers the chicken, brings it back to you. So there's a lot of overlap, a lot of cross-contamination. These are usually not done in very sanitary environments. It's very easy for a virus to get from an animal into a human there. The animal that they suspect is bats, which is not surprising. Bats are host reservoirs for a number of different human diseases. Ebola hangs out in bats, rabies hangs out in bats. Now, this does not mean go out and kill all the bats. We like bats, they're very nice. But, you know, don't eat them. We know that COVID can be spread from person to person, not quite as easily as some, but it is easily transmitted. Signs and symptoms of coronavirus usually stop with a fever, with a dry cough. SOB does not mean son of a something. SOB means short of breath. So your patient will have a dry cough, be short of breath. The loss of taste and smell, I think, is super interesting. I have not seen any studies that talk about why you get this loss of taste in your COVID patients. Hopefully you're lucky and that's all you deal with. If you get the more severe case of coronavirus, then you're dealing with things like pneumonia, respiratory distress because the lungs are filling up with fluid. And then this is one that's starting to come to the forefront of a lot of research into coronavirus, disseminating intravascular coagulation. Your patients start to get tons and tons of little blood clots all throughout their body. Why the virus is causing that, we're not entirely certain. The R0 for coronavirus is about 2 to 3 people. That's our estimate right now. I think 2 to 3, maybe 3.5. R0, it's spelled N-A-U-G-H-T. R0 is the reproductive number. So this means if one person gets sick with coronavirus, how many other people are they going to make sick? So one person who gets coronavirus will, on average, pass coronavirus on to 2 or 3 other people, which is not a super big R0. That's not bad, all things considered. We're going to look at another disease that has an R0 that's about 9 times that. That's really bad. The incubation period for COVID-19 is about 2 days to 2 weeks. Again, these are estimates because we're still learning so much about this virus as we go. By incubation period, we mean what is the time frame between when I get infected with the disease to when I start showing symptoms. So yesterday I went to King Soopers to get stuff for dinner and to get toilet paper, and while I was there, someone was coughing in my face, and then 10 days later I woke up with fever and chills and a cough, and I couldn't taste anything. That's what we mean by incubation period. So why do they call it corona? Gosh, wouldn't we all love to be there right now? That'd be wonderful. We call it Corona. It does not have anything to do with Mexican beer. We call it Corona because of these little spikes surrounding the outside of the virus. Corona is Latin for crown. They look a little bit like a crown. This is a hallmark of all coronaviruses, not just our COVID-19. So is there a treatment for COVID-19? Currently, there is no treatment. There are a whole bunch of drugs in research right now. One of the most promising looking ones is remdesivir. It's a broad spectrum antiviral medication. It was originally developed to fight off hepatitis C, wound up being singularly unimpressive. So antivirals are very, very expensive and very difficult to make. So the researchers decided, well, we'll look at whatever else we can use. They tried it against Ebola, they tried it against Marburg, which is another kind of scary Ebola type virus. Didn't really do a whole lot there either, so then they started testing it against coronaviruses, against SARS and MERS, and that looked a lot more promising. It seemed to do really well against SARS and MERS. Right now there are a whole bunch of studies going on with remdesivir, and so far they seem to be fairly promising. This I pulled out of a study from the NIH. Some really nice stuff here. So patients on remdesivir had 31% faster time to recovery. This P less than 0.001 is really good when we look statistically. Median time to recovery was 11 days for patients with remdesivir, 15 days if you didn't get it. And then mortality rate, only 8% of people on remdesivir died versus 11%, almost 12% for the people who didn't get remdesivir. And again, this p-value right here is pretty good when we're looking at statistics. So overall, hopefully promising. There are, like I said, a lot of studies going on right now, and it will be a while until we figure out what is our go-to drug for treating this virus. This is from the CDC. These are all of our confirmed cases of CDC. As you can see, there are 3 countries in the world that are not reporting any COVID cases. One is our friends up here in North Korea. One is Turkmenistan. Interestingly, Turkmenistan had a really big crackdown on any mentioning of COVID-19 in the news or in the media. And then Western Sahara over here next to Mauritania and Morocco, which is kind of a notoriously unstable region, so I'm not surprised if they're not reporting COVID-19. They're very busy trying to keep people alive there. So do you think that there is no COVID-19 in North Korea or in Turkmenistan? If all of the houses surrounding you are burning down, is yours burning down too? Yes, most definitely. So just because Turkmenistan is kind of sticking their fingers in their ear, and North Korea as well, we're pretty certain that COVID-19 is all across the globe. Those of you who have ever played Plague before, you know the next step. Now you have to beat the virus before the virus beats you. All right, let's talk about a happier disease. How about tuberculosis? 1 person dies from TB every 20 seconds worldwide. So that's 3 people a minute, 180 people an hour. That's a lot of people. That's a lot of tuberculosis. TB is a bacterial infection. It's spread through the air when someone coughs or speaks or sneezes or sings, very similar to coronavirus. Most people who have tuberculosis actually can't infect someone else. They have what we call latent tuberculosis. Latent just means like hidden. So latent tuberculosis, you have the bacteria chilling in your lungs, but it's not active. It's not causing an infection. About 13 million people in the US who have latent TB, and a very small percentage of them, between 5 to 10%, will develop active tuberculosis. Now, the challenge is figuring out who is that 5 to 10%. That can be difficult. We do know that if you are HIV positive, you are 20 to 30 times more likely to develop active tuberculosis than someone who isn't. And you'll see a lot in big hospitals that do a lot of tuberculosis treatment and HIV treatment. Usually the HIV and the tuberculosis wing will be the same wing of the building because they're assuming that if you have one, you're going to get the other. The treatment for tuberculosis is a 3 to 4 drug regimen that you take for about 4 months. Think about the last time that you were on prescription drugs. What was that like? Did you finish them? If you didn't, you can say no, it's okay, I'm not going to tell. And you probably only had to take those drugs for, what, a week and a half, 2 weeks maybe? So if you're struggling with one medication for 2 weeks, you guarantee you that your patient is going to struggle if they have, 4 drugs for 4 months. And it's really important to make sure that your patient with TB is taking their medication properly, because if they're not, this contributes to drug resistance in our tuberculosis. Drug resistance simply means that the tuberculosis can't be killed off by the antibiotic that we would normally use to kill it off. Drug resistance is increasing in tuberculosis, and the more drugs that you cannot use to treat tuberculosis, the more your cure rate goes down. So in patients who are multiple drug resistant, we see only 54% of them can be cured of TB. In patients who are extreme drug resistant, only 30% of them can be cured of their TB. There have been a few cases of complete drug resistance in tuberculosis, where we see strains of TB that cannot be treated by anything. There was a case in Italy, there was one in Israel, there was one in Iran, where we just don't have any drugs that will work against it anymore. Right now, there are a whole bunch of different vaccines in research for tuberculosis. We do have one vaccine that is pretty commonly used in the developing world or anywhere outside of the US, called the BCG vaccine. This is given to young kids, and it generally protects against some of the more serious complications of tuberculosis, like encephalitis. You'll see sometimes neurological issues with tuberculosis. It doesn't really protect against the respiratory stuff, though, unfortunately. We don't give the BCG in the US just because we don't have a lot of tuberculosis here. My last class that I had, they were all born and came from Mexico, and when we talked about BCG, they all figured out that was the little scar on the outside of their arm, and they got really excited about that, and they talked about the Mexican shot for the rest of the night. So if you were born somewhere outside the country, chances are very good that you had BCG. Check the outside of your upper arm. You probably have a little small round scab or scar there. That's where you got the BCG tuberculosis shot. So these are different types of tuberculosis. You can see our latent infection over here on the left. Again, latent means hidden. So this is not an infection. This is just the tuberculosis chilling in your lung. In cavitary tuberculosis, you see cavities in the lung. The tuberculosis is eating its way through the lung. In our miliary tuberculosis over here, we just see lots of tiny little infections spread all through the lung. In either of these, both of these right here, you can imagine why your patient is coughing up blood, why you see hemoptysis in your patient with tuberculosis, because of all of that damage that's being done to the lung. On the left here, we see a radiograph of a nice healthy lung, and there's not a whole lot to see. We see, here's the beginning of the bronchial tree right here, some bronchi at the hilum of the lung. And then the rest of this is pretty clear, as it should be, because there's not a lot in your lungs. Your lungs are soft tissue and air, neither of which really show up on an X-ray. On the right over here, we see a bit of a hot mess. We see all of this right here. Here's this going up into here. That's bad. You also see kind of a lot more cloudy, a lot more opaque than we see on the other X-ray. This person has an active TB infection. Hopefully they're taking their drugs properly. My sister sent this to me. I love this. Sometimes you try to make an inspirational meme. Sometimes you just give somebody tuberculosis. Emphysema is caused by destruction of the alveoli. They overexpand, they destroy, and they kind of fuse together. What this winds up, instead of lots of tiny, tiny little alveoli all kind of packed together, you have a few great big alveoli all together. When this happens, you lose the surface area of your alveoli, and not as much oxygen travels from the alveoli into the bloodstream. Different causes of emphysema. Cigarette smoke is probably the biggest one. Smoking will damage and destroy your alveoli. If you live somewhere where there's really bad air pollution, if you are constantly dealing with lung infections, that will lead to emphysema as well. Emphysema is classified as chronic obstructive pulmonary disease, COPD. It's one of our 3 COPD diseases. Emphysema is one. The other one is asthma. The other one is chronic bronchitis. All 3 of those fall under the category of COPD, and I would know that for the quiz on Wednesday. So let's look at asthma. Asthma occurs when you get narrowing of the bronchi. Usually this is triggered by some kind of allergy. In your asthmatic patient, the bronchi are normally narrower than they would be in a healthy patient. The main thing that you see with asthma is this irritation from an allergen that leads to then constriction of the bronchi, buildup of fluid in the bronchi, and then wheezing and difficulty breathing. If you get really extreme asthma attacks, then you wind up with this dyspnea, which is difficult or painful breathing. Cyanosis, your patient might turn blue if they're really having trouble breathing. So normally this is what your bronchioles should look like, and they look nice and open. Those smooth muscles around there are really relaxed. In your patient with asthma, this is what the airways normally look like. The wall of the airway is more inflamed. It's a little thicker. The smooth muscles are a little inflamed as well. Now then, when your patient has an asthma attack, then we see not only do the smooth muscles of the airway tighten and inflame, but then you see all of this buildup of mucus and fluid in the bronchus that makes it very hard for your patient to breathe. Now, what do we think of when we think of like asthma attack and treating an asthma attack or medication for an asthma attack? Hopefully your first thought is, oh, well, we need to go get this patient's inhaler. And an inhaler in an asthma attack will help you go from here to here, will reduce the inflammation in the wall of the bronchus, will reduce the production of fluid and mucus that's blocking off the bronchus. But maybe you have seen or heard advertisements for medications for patients with asthma, and then they talk about this does not replace your fast-acting inhaler. Use this once a day. This is not what you use during an emergency. You've probably heard those ads before. If not, look up an ad for asthmatic stuff online, or if you haven't, I can find one for you. Those medications that they're talking about that you take once a day, it doesn't replace your inhaler if you have an asthma attack. Those are designed to take you from here to here, to go from this asthmatic constricted airway to a normal airway. That's why you're taking that medication once a day. Pneumoconiosis. If you or a loved one has suffered from mesothelioma, there are a lot of ambulance chasers on the daytime talk shows who would like to talk to you. So we've all heard the ads for mesothelioma. This ties into pneumoconiosis. Pneumoconiosis is chronic irritation of the lung caused by inhalation of dust particles. You would see specific types of pneumoconiosis based on specific exposures. You see this a lot in people who do mining or people who work with stone or with glass, and people who work with asbestos. There are different types of pneumoconiosis. Silicosis is caused by exposure to silica or quartz. You breathe in lots and lots of tiny, fine silica or quartz particles all day for years and years on end. That's what we see here in this lung. If you look, you see it almost looks like little strings of pearls in the lung right here. These tiny little lumps right here. Those aren't supposed to be there. Your lungs are supposed to be nice and flat and smooth and pretty. They're not supposed to look like that. That happens when you have lots of silica or quartz dust in the lungs, and the lungs build up scar tissue around that silica or quartz. But then that means that it's impeding air into the lungs. Air is not going to get into the lungs as well as it would. Anthracosis, you sometimes hear called Coal miner's disease, coal miner's lung, black lung, that's what we see over here. This patient who spent, probably 40, maybe 50 years working underground in a coal mine, breathing in all of that coal dust that gets embedded in the lungs. You can imagine before this patient died, he probably had a lot of trouble breathing. And then asbestosis is caused by exposure to asbestos fibers, which were commonly used in building, especially for insulation. Asbestosis looks very similar to silicosis in the lung, and asbestosis can lead to mesothelioma, which is a very specific type of lung cancer that you only see in patients who have been exposed to asbestos. Now, the reason why there are a bunch of people on your daytime talk show interrupting you watching Maury talking about suing people for mesothelioma is because the asbestos industry knew about this connection between asbestos and mesothelioma for a very long time, and they covered it up. They funded studies trying to prove that mesothelioma was caused by something else. They denied, until finally there was kind of irredeemable proof that asbestos caused mesothelioma. And then that's where all of the lawsuits came from. That's why there's people seeing, trying to find who out there has been affected by mesothelioma. Interestingly, you saw the same thing happen with the cigarette industry. Cigarette companies did their darndest to cover up the link between cigarette smoking and cancer. They published all kinds of studies, funded all kinds of studies. They put out one study that said people who are born in March have a higher risk of lung cancer, and that's why these smokers were getting cancer. Until finally there was enough evidence, they just couldn't deny it anymore. If you're interested in this kind of thing, or if you're looking for some reading while we're all in quarantine lockdown, there's a very interesting book on this topic called Doubt is Their Product that talks about both the asbestos and the cigarette industry. Lung cancer is the leading cause of cancer deaths in men and women in the US. Over 25% of cancer-caused deaths are from lung cancer. The major factor in lung cancer is cigarette smoke. That's usually what you think of with lung cancer, but a good 25% of the people who develop lung cancer have never smoked a cigarette. So other things that you see with lung cancer, secondhand smoke, thirdhand smoke, asbestos we talked about earlier, mesothelioma. Radon is a radioactive gas that is made in the ground when granite breaks down. There's a lot of radon in the ground in Colorado because there's a lot of granite in the ground. And then exposure, there's our air pollution again that we talked about earlier. So third-hand smoke. What the heck is third-hand smoke? Okay, what's second-hand smoke? Actually, let's back it all the way up. First-hand smoke would be what? That would be you sitting outside on your break, puffing on a cigarette, right? First-hand smoke. I'm smoking, and all that smoke is coming into me. Secondhand smoke, then, is you sitting next to the person who's outside on break puffing on a cigarette. You're not smoking, but you're being actively exposed to what they're smoking. So what then do you think is third-hand smoke? Third-hand smoke, have you ever rented a car or gotten a hotel room and you walk into the hotel room or you get in the car and you take a breath and you go, oh, someone's been smoking in here? You can tell pretty easily when someone's been smoking somewhere. And that's because the smoke particles embed themselves in everything, in the fabric, in the carpets, in the walls, in the furniture. And you're being exposed to those smoke particles even though there's no one actively smoking. So this would be something like, mom doesn't smoke in the car while the kids are in the car. She only smokes in the car when she's there by herself. Or dad doesn't smoke in the house. He smokes out on the porch where the kids, aren't around, but then he's coming back into the house covered in smoke particles. So even that can increase your risk of lung cancer, even that exposure. Lung cancer is hard to detect. It spreads through the body very easily. That's what metastasizing means. Metastasizing just refers to cancer spreading from the organ where it started to another organ in the body. The overall survival rate for lung cancer is pretty low. Only 18% of your patients will still be alive 5 years later. You diagnose lung cancer using usually an X-ray or a bronchoscope, sticking a camera down in the lungs to take a picture of what's going on. Respiratory distress syndrome means a few different things. Acute respiratory distress syndrome is what we're seeing right now in our COVID patients. They get this buildup of edema, of fluid in their lungs, and that makes it very, very difficult to breathe. You see this also in little babies and premature infants because they do not have this protein in their lungs called surfactant. Now, I want you to back it up, way up. Think about elementary school many, many years ago, first, second, third grade. Think about the overhead projector and the lamination sheets in class. Someday I will pull out this analogy and none of my students will know what I'm talking about. So far I've been lucky. When you are the unfortunate sap who has to take that stack of lamination sheets to the sink and go wash them off, so you take them, you drop them all in the sink, you turn on the water, and then what happens? All of your little lamination sheets, those little plastic sheets, they stick to each other. And you can't pull them apart or peel them apart. The same is true of your alveoli inside your lungs. When you are chilling in a uterus before you're born, your alveoli are stuck to themselves. The insides of your alveoli are collapsed on themselves, which is fine. I mean, what are you going to do in a uterus? Breathe. But around month 8 or so, you start making this protein called surfactant. And surfactant serves to break up the surface tension of the water in the alveoli so that when you're born, you will be able to breathe. The equivalent of this is going back to you and the sink and the lamination sheets. If you take the soap bottle and put a little bit of soap in there, in between those lamination sheets, all of a sudden it breaks up the surface tension and you can separate them and they'll slide back and forth. That's the same thing equivocally that we see with surfactant in the lungs. So it's not made until month 8 or so of pregnancy. So then what does that mean about our little 22, 23-week-old preemie? They don't have any surfactant. So their alveoli are collapsed on themselves and it's going to be very hard for them to breathe. Now you can inject surfactant into their lungs. You can give them a cortisol shot that will stimulate the body to start making surfactant. But little premature babies spend a whole lot of energy trying to breathe because they can't, because they don't have that surfactant to help open up their alveoli. You can see here the difference between our nice normal open alveoli versus these really collapsed ones. You're not going to get a lot of air into those alveoli on the right. Cystic fibrosis is a genetic disease. It affects the way that chloride moves across your cells, which ultimately means that you get really, really, really thick, sticky mucus in the lungs. This makes it really hard for that mucociliary escalator that we talked about earlier to carry that mucus out of the lungs, and this increases your patient's risk of infection. Usually a patient with cystic fibrosis is constantly fighting off some amount of low-grade infection. They're usually on antibiotics their whole life to deal with that. We diagnose cystic fibrosis by looking at the amount of salt in your sweat. Patients who have cystic fibrosis have very salty sweat. This is a test that's done on all newborn infants in the US. It's a pretty fast, easy test. Because this is a genetic disease, there is no cure for cystic fibrosis. And the lifespan for cystic fibrosis right now is about 37 years, mid to late 30s. Your patient with cystic fibrosis will generally die because of a lung infection. Now, 37 years does not seem like a lot of years, but about 20 to 30 years ago, that lifespan was something like 16 or 17. Patients with cystic fibrosis would die in their mid to early teens. So there's been a lot of progress made on treating this condition. Cystic fibrosis is interesting. It's one of our diseases that tends to have a strong racial or genetic bent to it. We see sometimes diseases that show up in one ethnicity versus another. Tay-Sachs disease, for example, is seen, almost exclusively in Ashkenazi Jews. Sickle cell anemia that you probably talked about last week, you see in populations that are African, Middle Eastern, Mediterranean, Indian descent. Cystic fibrosis is kind of your classic white person disease. You see this in people who descend from Northern Europeans. You do see it sometimes also in Latinos and in Native American populations as well. Between 1 out of every 25 to 1 out of every 16 people is a carrier for cystic fibrosis. They have one copy of the gene. You need to have 2 to be affected. And it affects 1 out of every 2,500 babies born, so a fairly common genetic condition. Cystic fibrosis affects, just about every system that you have, more than just your lung, but your lungs are the ones that usually we're concerned about when we're dealing with someone who has cystic fibrosis. You can see how that really thick, sticky mucus is blocking off the airways in our patient's lungs. So what do we do about that really thick, sticky mucus? There are drugs, mucolytic drugs, that you can give your patient that will help to break down that mucus, and then you need to get it out of the lungs somehow. So there are a couple of ways that we can do that. One is postural drainage. You place your patient in a certain position. That's what we see in this top right up here, based on which part of the lung you want to drain. And then with a cupped hand, you tap on the lungs gently on the chest to loosen the mucus in the lung. And then you give your patient a little shake that shakes the mucus loose, and then they cough it up, and then you continue. This is kind of time consuming, and obviously it takes another person to do. So if you don't have another person, or if you need this done more frequently, a very popular option is what we see up here with this little cutie, her little vest that she has on. There's pressurized air that moves through that vest, and it vibrates and shakes her body and shakes the mucus loose in her lungs, and then she's able to cough that up. Most people who have cystic fibrosis will undergo some kind of vest treatment or postural drainage, usually in the morning and in the evening. If they are really having a hard time, maybe they've got a lot of lung infections right now, they might use the vest more frequently. SIDS, or sudden infant death syndrome, is any unexplained death of an infant 1 year of age or younger. Usually happens during sleep, usually without much of a warning. You do tend to see this a little more in premature infants. To keep this from happening, really important that you keep the baby on their back while they're sleeping. And the hypothesis behind that is that if you have a really small baby, they're not able to roll themselves yet. If they're sleeping on their stomach and they throw up in the middle of the night or they regurgitate, they're not able to lift their head and clear their mouth and clear their airway. We also know reduced exposure to smoke, making sure that the baby's not overheated, that they're not covered in blankets and pillows. All of those will also help with reducing incidence of SIDS. The sleeping on your back is probably the most important one. This is a chart from the National Center for Health Surveys from the CDC, and this shows the rates of SIDS on a decline as information about the American Association of Pediatrics' recommendation that babies sleep on their back increases. So the percentage of babies sleeping on their back is increasing, the rates of SIDS are decreasing, so we definitely see a correlation there. Let's talk about some vaccine preventable diseases, some more infectious diseases. Whooping cough is spread by the bacteria Bordetella pertussis. It's spread through droplets in the air that are let out when you cough or speak or sneeze or sing, much like tuberculosis. The incubation period for whooping cough is about a week to a week and a half. There are 3 stages to a whooping cough infection. The first stage is what we call the catarrhal stage. It lasts a week or 2. Mild cough, sneezing, runny nose, fever. What does this sound like? What do these symptoms sound like? Sounds like my kid has a cold. He's fine. Kids get colds all the time. After that first 2 stages, though, you then go into this, or that first 2 weeks in that first stage, you go into this paroxysmal stage. And this can last from 1 week to 6 weeks. It can go up to 10 weeks. So anywhere from a week to 2.5 months. And in this paroxysmal stage, you see this rapid cough with this whoop at the end. This is where whooping cough gets the name, because the kid is coughing so hard, they're trying to get air back into their lungs as much as possible. This coughing can lead to vomiting. Think about the last time you coughed so hard you almost threw up or were afraid you were going to throw up. It can lead to cyanosis, to your patient turning blue. It's very unpleasant, and it goes all day and all night too. There's no really stopping it. After you make it through that paroxysmal stage, then we get to this convalescent stage that lasts anywhere from 2 to 6 weeks, but can go up to months. And during this convalescent stage, if you get some kind of respiratory infection, maybe your patient has the flu or a cold, that can send them back into the paroxysmal stage with the really bad cough and the whoop. During this time, this convalescent stage, you're still contagious. You can still make someone else sick. So my kid had whooping cough. He coughed for like 3 weeks, but he's fine now. He's over it. We feel better. Let's send him back to daycare. And then there's a potential of him spreading that whooping cough through all the kids in daycare. Morbidity and mortality that we see with whooping cough: you can cough so hard that you crack or break a rib. Obviously, lots of chest pain. Pneumonia is not uncommon with whooping cough. 1 out of 20 cases will get pneumonia. The big concern with whooping cough, the big population that's at risk when we talk about whooping cough, is babies. In infants, you see seizures, you see loss of consciousness because they have very low oxygen levels, and our little infants who are less than 6 months of age are most likely to die from a whooping cough infection. They just can't handle that really, really strong infection. There is a really good vaccine for whooping cough. This is our Tdap vaccine. The whooping cough is the AC, or the AP part of the vaccine, the acellular pertussis. This is a 5-dose series. You give the first shot at 2 months, the second shot at 4 months, the third shot at 6 months, the fourth shot in between 15 to 18 months, and then the fifth shot between 4 to 6 years. Infants are not protected from whooping cough until they've had that third shot. So hopefully now that makes sense why babies under 6 months of age are most likely to die from whooping cough, because they have only had dose 1 and dose 2 of their Tdap vaccine. They're much more likely to not be protected all the way. There are other people who should get whooping cough injection or whooping cough booster as well. Pregnant women usually will get a booster kind of later on in pregnancy. Anyone who's going to be around babies, newborn babies, should get a booster as well. Herd immunity threshold for our whooping cough vaccine is 92 to 94%. Getting so many public health and epidemiology terms in this lecture. Herd immunity threshold means what percentage of our population needs to be immune, either by getting whooping cough or by being vaccinated, in order to prevent an outbreak. So 92 to 94% of our population needs to be immune to whooping cough in order to prevent whooping cough outbreaks. That's a huge percent. That's almost everybody needs to be vaccinated against whooping cough. Currently, actually not currently, this is from 2017, only 83.4% of children between the age of 19 to 35 months old, so that's children right here, they got their 4th dose, they need their 5th. Only 83% of them have their complete Tdap coverage. So should we expect to see outbreaks of whooping cough in this population, in these 19 to 35 month olds, if only 83% of them have their whooping cough vaccine? We should expect to see it, and we do see it. We do see outbreaks of whooping cough because of that low vaccination percentage because we haven't met that herd immunity threshold yet. So stuff that you'll see with whooping cough, your patient can cough so hard that it causes them to burst blood vessels in and underneath their eyes. You'll sometimes see cracked or broken ribs. You can imagine that's very, very painful. Rates of pertussis have been increasing steadily over the last 20 to 30 years. This is from the CDC. We can see just this gradual line of fit showing a pretty good increase in rates of pertussis, and specifically in our youngest populations because they're not completely protected against that pertussis by the vaccine yet. If we back it up a little bit more and look back to the early 1900s, you see really, really high rates of pertussis for a while. We had this crazy peak back in like the mid 30s at about 26, 27 100,000 cases of pertussis in the US. With the introduction of the Tdap vaccine, we start to see a very rapid decrease in pertussis over the course of about 20 to 30 years. And then we see this kind of start to ramp back up again, starting around 1990. In 1990, we went from fewer than 10,000 cases of pertussis to this peak up here in probably 2014, where we hit about 45,000 cases of pertussis. So it increased very quickly over a very short amount of time, which shows that we really need to ramp up what percentage of our population is actually getting vaccinated against pertussis. Another of our vaccine preventable diseases is measles. The other name for this is rubeola. Sometimes you'll hear sort of the old school doctor or nurse call it rubeola. Measles is a viral infection. It has about a 10 to 14-day incubation period, which is pretty standard for a virus. First signs of measles: runny nose, mild fever, cough, sore throat. Again, this sounds like my kid has a cold. Little kids get a cold all the time. He'll be fine. You may or may not see conjunctivitis, which is inflammation of the membranes around the eye, commonly called pink eye. And then after those first kind of cold and flu-like symptoms, you get into this very, very noticeable rash. I'll show you a couple of pictures of it. Once you see it, you'll never forget it. And a very high fever, 104 to 105 degrees. At about 106 degrees, your brain starts to have issues with that temperature. So a fever of 104 to 105 is sort of flirting on the edge. Now, important to know, you can spread that virus up to 4 days before the rash appears, and then up to 4 days after the rash appears. So little Johnny has a cough, but I'm sure he's fine. I'm sending him to daycare because I have to go to work. Right? Is it possible that Johnny's in daycare running around giving out measles like Oprah gives out cars? Quite probably. Measles is spread through droplets in the air the same way that tuberculosis and pertussis are spread, and it's super, super contagious. If you have a room full of people who are susceptible to measles, either they haven't been vaccinated or they have a very weak immune system, and you traipse someone with measles through that room, 90% of the people in that room are going to get measles. Measles has an unspeakably high R0. Remember the R0 of coronavirus was about 2 to 3. The R0 of measles is between 12 to 18. So one case of measles will cause between 12 to 18 new cases of measles. That's astronomically high. Not even Ebola or HIV have an R0 that high. Ebola's R0 is about 4. HIV's R0 is also about 4 to 5. So it's very, very easy to spread measles around in a population that doesn't have a lot of measles protection. This is the measles rash. You'll notice it doesn't look like chicken pox. It also doesn't really look like hives, and it's pretty unmistakable. Once you see it, you'll never forget it. Also, note the age of all the children in these pictures. These are very young babies. There is a vaccine for measles, the MMR vaccine. This is a 2-dose vaccine. You give the first one between 12 to 15 months. You give the second one from between 4 to 6 years. And those 2 doses are wildly effective against measles, 97% effective against measles. Our herd immunity threshold for measles is even higher than our herd immunity threshold for whooping cough. Between 93 to 95% of your population has to be vaccinated in order to prevent a measles outbreak. Now, patients who should not get the vaccine, patients for whom it is contraindicative, would be a patient who is immunocompromised. This would be something like a patient who is having chemo or a patient who is born without a functioning immune system, because that can happen sometimes. And then, of course, if you're allergic to the contents of the vaccine, you should not be getting the vaccine either. There's a lot of data going on in this page right here. There are a few things that I just want to point out. This is data from 2017, so a few years old, but I think the trends that we see are still holding steady. So up here in the top left, the darker that your state is, the higher the percentage of vaccine coverage. So places like, for example, Minnesota is really dark, so they have pretty high vaccine coverage for MMR. North Dakota, I mean, there's only like 6 people living there, so they all got shot for MMR. Virginia has really good MMR coverage. And then we get to the land of the free and the home of the brave. So Colorado is not super good at MMR coverage. Here's where we are down. We're almost dead last. We're like second or third from last place when it comes to vaccine coverage. Only 87% of kids between 19 to 35 months old have their first MMR vaccine. So should we expect to see measles outbreaks in Colorado? Yes, because remember, our herd immunity threshold was between 93 to 95%, right? And we only have 87.2% of our population that's vaccinated. So we should expect to see measles outbreaks, and we do see measles outbreaks. Okay, going from our infectious diseases, we're going to talk a little bit about issues of the pleura. Pleurisy is inflammation of the pleura. You usually see this with infection. You'll see it with stuff like pneumonia, for example. I'm sure a lot of our COVID-19 patients have pleurisy. Your main symptom of pleurisy is just pain. It hurts to breathe, so your patient doesn't breathe a lot. They breathe very quickly, very shallow breaths, because it's so very, very painful. You can see buildup of substances, buildup of fluid or air in between the layers of the pleura. You can see it with air if you get a pneumothorax with pus or blood or fluid. And that's concerning because then that fluid compresses the lung and makes it harder for the lung to expand. I'll show you a picture. So if you do have a patient that has fluid in here, in between the layers of the pleura, you're going to have to do a thoracentesis to get that fluid out between those layers of the pleura. You may never have heard of a thoracentesis, but if you have ever been pregnant, you may have heard of an amniocentesis. Centesis means to puncture for fluid removal. In an amniocentesis, you're puncturing the amniotic sac to remove fluid from the amniotic sac. In a thoracentesis, you're puncturing the thoracic cavity to get fluid from the pleura. If you needed to do, get spinal fluid from your patient to test for maybe meningitis, you would do a lumbocentesis to puncture the lumbar vertebrae and get fluid from around the spine. So this is what I mean here by that fluid building up and compressing the lung. You can see the lung is getting smaller because that fluid is squeezing it. We need to do that thoracentesis to drain all that fluid off of the lung. So different diagnostic techniques that you see for respiratory disorders. Obviously, your good old radiograph is a good place to start, but it won't always show up a lot of the detail that you need. So quite often, if you get your radiograph back and you're not impressed with the information you got or the lack of information you got, you'll throw your patient in a CT or an MRI. Bronchoscopies are very common as well. And then again, testing the fluid that you remove when you do a thoracentesis to see what's causing your infection. Arterial blood gas examination is not something that you will learn how to do. This is a nurse thing. This is not a medical assistant thing, because it involves puncturing an artery. And normally speaking, when you're drawing blood off of your patient, you're drawing it off of a vein. The artery in question that you use for an arterial blood gas draw is the radial artery in the wrist, along the thumb in the wrist. And you just basically go straight down really hard with a needle and a syringe into that artery, because arteries are very hard to puncture. Remember, they have very thick muscular walls. You do this to see how gas is moving from the lungs into the blood, and you look at a few different gases that you do with that. As soon as an arterial blood gas is drawn, it has to go on ice so those gases don't dissolve out of the blood. Now you will learn how to do, when we get back to campus, may it be soon, you will learn how to do a pulse oximetry. This is the little red light that they put on your finger when you go to the doctor. This measures how much oxygen is in your blood. And usually this should read out something like 97, 98%, maybe 96% because we're at fairly high elevation. If your patient's at 95% or lower, that's going to make the doctor kind of nervous. If your patient is like 85% or lower, they need to be put on oxygen and probably admitted to the hospital. Something very bad has happened. Pulmonary function tests are done using a spirometer. This measures how you move air in and out of the lungs. I will post a little video of a spirometer in action so you can see that being used. There are different amounts of air that you'll measure moving in and out of the lungs with a spirometer, and that will tell your pulmonologist different things about how the lungs are functioning. A few terms to know: tidal volume refers to just the air that you're moving in and out of your lungs when you're breathing normally, as you guys are sitting here breathing, hopefully, listening to lecture. Inspiratory reserve volume would be if you take a few normal breaths and then breathe in as much as you can, as deep as you can. That's inspiratory reserve. That's how much extra air could you breathe in if you needed to. And then if you take a few normal breaths and then you breathe out as hard as you can, that gives you expiratory reserve volume, which is how much air is still left in your lungs after you just normally breathe out. Again, changes in numbers in these will mean things to a pulmonologist who is well trained at reading these. And that is that for our respiratory system lecture. I know it was very long. Thank you for hanging in there. Hopefully you took a break once or twice. Lots of key terms at the end of the PowerPoint. I'm not, again, going to read over these because you don't want to read all of them, though I will point out one that would serve you well to know for the quiz on Wednesday. So hopefully you found something interesting in here. If you have any questions, or if you would like to get further information about a topic or talk about something, you know how to find me in office hours or can send me an email. And thank you for dropping by.